Hi, I'm Dr. Scott Laborowit, and this is video for residents on capsulotomy. Some basic considerations are, as you enter the eye to turn the needle flat, you want to fill the anterior chamber full of viscoelastic, and your initial pierce of the capsule shouldn't be too deep or you'll stir up the cortex and lose visualization. Also, as you angle the needle down, don't end up too proximal. When you drag, keep the needle flat and superficial, use the tip only, and make sure you leave enough room so you can see where you're going. You want to fill the anterior chamber entirely so you flatten the anterior capsule. Otherwise, it'll be curved, and as you're ripping the capsule, it can run downhill, so to speak. So you always want to be thinking three-dimensional. And as you enter the wound, you want to make sure you don't burp out viscoelastic and lose that advantage of flattening the capsule. And then also you see I turned the needle 90 degrees to not disrupt my primary incision. Be careful when you pierce to not go too deep or you'll stir up cortex, lose visualization. And then move horizontal and then start to come down. Don't move horizontal until you've pierced the capsule and then start your movement. Here you can see I set the flap up for the grab and it's not too far subincisional. So now I can easily grab the capsule that's been left in a position, not subincisional and easy to grab. I'm starting to induce too much striae, so you want to recognize that you're in control. So you'll see that I pivot the instrument away from the edge of the wound to get the striae to go away. So you want to always be conscious that if you lose visualization, it's because you're turning the eye or inducing striae. As I'm needing to turn in different directions, I'll re-grab. And this is, I call the power grab. It's where I'm 1 millimeter away from the edge of the rip, and I keep it flat. And when I'm in that position, I have control. So especially when I'm in tough spots, I'll use that. Make sure you look once the implant's in and give yourself a grade. The implant's 6 millimeters, so you can see how well you did with your capsulotomy centration and size. Some other considerations is if the eye moves, it's your fault, so keep the eye straight for a good red reflex. And think about strategy-wise where you want to start your capsulotomy and what quadrant do you want to begin in, how can you set it up best so subincisionally you don't have to re-grab, which is the most difficult area. So this is a second case. You can see as I enter the eye, I turn 90 degrees. I make sure I'm not burping out viscoelastic so I can keep the eye filled. So here I want to decide what quadrant do I want to begin. So when I'm creating the capsulotomy through the subincisional space, it's the best situation. So I'm coming more in the middle of the eye, going horizontal and pulling down, and I'm leaving the flap folded over. Once you pierce the capsule, you want to make sure you're using the needle only with the tip. So again, I'm hurting my view with this induced striae. So you'll see me pivot to get the eye straight, but I get my instrument off the edge, and now I can see what I'm doing better. Also notice that I grabbed the capsule before I went subincisional, and I didn't re-grab again until I was in a position that was away from the subincisional space. And then once the implant is placed, just make sure you take another look and see how you did on your capsulotomy. Give yourself some feedback. I start the viscoelastic through my primary, but I also start distal to proximal to get rid of the air bubbles. And it's very important for me to have the eye as full as possible to keep that anterior capsule as flat as possible. Sometimes once you're about to stick your needle in your strategic area to start your capsulotomy, As you bend down in a deep eye, you end up a millimeter closer to the wound and end up creating a flap that's a little more difficult to grab. So you want to be conscious that if it's a deep eye or a deep anterior chamber, that as you kind of decide where you want to pierce and then you angle down, that you don't come too proximal, that you stay and pierce in the intended area. Again, another example of making sure that I can easily grab when I start and come across the subincisional space, which is the most difficult to re-grab and visualize. And then it's a little hard to grab here, almost backhanded, the flap, but you want to leave it set up so you can. And then here you see I'm in the power position where it's a harder turn, so I'm 1 millimeter away, pulling somewhat flat as I rip. You can get in trouble at the end of a capsulotomy if you just pull it like I just did. So often I'll re-grab at the very last clock hour because I'm concerned that it might run out at the end. So you just want to be careful not to get lazy, and it only takes one case to then change the way you do it from now on. Once you do several capsulotomies, you'll get in a habit of strategically creating a flap that's reproducibly easy to grab. You'll find yourself pulling across the subincisional space, sometimes not even always circular, but making up for the size or the roundness of your capsulotomy in the other areas or quadrants. Notice that there's not viscoelastic burping out of the wound. If there was, I would refill the eye so I don't have the risk of creating a larger or a rent because there's a curve on the anterior capsule. By keeping it filled, you're ripping on a very flat capsule. This is a situation where I do re-grab because you will get burned on that last clock hour thinking you're done. So I went to my power grab and I was able to complete the capsulotomy. This is just a review of some of the concepts we covered, and also capsulotomy considerations. Thank you very much.